Second.
Okay.
We are live in 5, 4, 3, 2, 1. We are live now.
Okay. Good evening, all. Once again, I welcome you all for this ASSI Global Outreach Program. And today we have a very interesting session with Bangladesh Spine Society. This is topic is on thoracolumbar fractures. And from Association of Spine Surgeons of India, I request our past president, Dr. H.S. Chabbra, sir, to welcome all the faculties and delegates.
Hello, good evening. Welcome to the ASSI Global Outreach Program. And we are privileged in that we have the honor of today collaborating with Bangladesh Spine Society for this program. I'm sure that since we face almost similar issues in our countries, this will be a great platform to discuss on various aspects of management of thoracolumbar fracture, the common issues that we face, the opportunities that we have, and how we can frame guidelines which would suit our countries. So with that, I would not keep you away from this fantastic session which has been planned. Over to you, Guru Raj and Rishi.
Thank you, sir. I just would like to ask Dr. Shah Alam, President of Bangladesh Spine Society, to say a few words, and then we'll start the program.
Thank you, Guru. Good evening, Chabbra and other lands from India. Special thanks, Guru and his team for organizing a joint collaborative webinar with Bangladesh Spine Society and Association of Spine Surgeons of India and in their global outreach program. It is true, the topic is very pertinent. Thoracolumbar fracture, how we are dealing, and India subcontinent with the same problem. So I think these discussion will be very, very helpful, and also it will guide all of us how to deal and when to change our recent advancement and modification of recent ideas. So everything going to be discussed, I think it will be very, very helpful to everybody. So with these few words, I again thanks especially including me and my society, and also Guru, because the Guru worked hard and also it was postponed and shifted. Even that successfully we are going to start. So I think in future also it will be helpful, and we'll organize the same combined program that will be helpful for everybody. Thank you once again to everybody.
Thank you, sir. So we'll start with the first topic that is from Dr. Ajoy Shetty. He's the past secretary and chair of Education Committee, ASSI. So he will be talking on timing of spine surgery in spinal cord injury. What has changed?
Thank you, Guru. Can you hear me?
Yes, sir.
Okay. Good evening to all of you. I also my thanks to the ASSI and Guru especially for this invite. My talk would be on surgical timing in traumatic spinal cord. What is new? We know that the spinal cord injury has got two mechanisms. The primary mechanism, which happens at the time of the accident, which we cannot do anything about. It's basically by legislation, what we can do to control the primary injury. But what we are interested is basically the secondary mechanism of injury, wherein there are different changes that is happening from the acute phase to the subacute phase to the intermediate and the chronic phase. As you can see in this diagram, during these phases, various phases, there is a cell death, demyelination, damage to the architecture of the cord, and there is restricted axonal regrowth. What we are looking at is how to limit this secondary mechanism of injury. There are various approach has been tried over the years. What we do know now is that vasopressor support is important to maintain a mean blood pressure of greater than 90 millimeters of mercury. Since the spine does not have the capacity to auto-regulate, it's important to maintain adequate oxygenation. On the other hand, we have tried various pharmacological agents like high-dose methotrexate, and we do now know that they are not that effective as we thought it was earlier. What we can do from our side is basically a surgical management. The surgical management in patients with a spinal cord injury has got two purposes. Number one, the surgical aim is to realign the spinal column, re-establish the spinal stability, and to decompress the spinal cord. But there is also a biological aim to the surgery. That is, when we are doing this, doing the surgical stabilization, if you do it early, it may help to prevent the zone of injury and to improve the clinical outcomes. If you look at the PubMed search on early surgeries for spinal cord injury, there have been an increased literature in the last few years, probably with understanding that things like stem cells may not be beneficial at this stage, and hence people are concentrating on something what they can do much more effectively. The earlier literature on early surgery meant less than 72 hours. But if you look at the literature, they say there is no difference in outcome between less than 72 hours and greater than 72 hours. But what really made the change is the famous STASIS trial, which looked at 24 hours outcome. And these studies have shown very effectively that if you operate less than 24 hours, definitely there is a different and improved outcome. And that came out with a call saying that time is fine. And as the earlier you operate, there is a better chance of improvement in the neurological conditions. And this is the outcome in STASIS trial, which shows a moderate degree of improvement. Therefore, early surgeries is beneficial in cervical spinal cord injury and is shown by multiple surgeries, and much more beneficial in incomplete spinal cord injuries. And this has been shown by multiple other publications which followed the STASIS trial. What are the things I would like to discuss? Does the level of injury affect the outcome? I mean, whether it matters, like early surgery has got a better outcome in cervical, thoracic, and thoraco-lumbar. If you look at the published literature up till the last few years, it is well known that improvement happens in early surgery in the cervical spine, but probably no major improvement happens in the thoraco-lumbar patient. But this is a recent publication which came out of Iran, which showed that early surgery group in thoraco-lumbar fracture also can have a benefit in terms of improvement in neurological outcome and also in terms of early discharge from the hospital. Therefore, what is the role of early surgery in complete versus incomplete spinal cord injury? I mean, as per the published literature so far, the benefit is mainly in Asia incomplete spinal cord injury, whereas in patients with complete spinal cord injury, there is no significant improvement in neurological outcome. And therefore, that puts the question, what do you mean by early? How early we should consider? We know that less than 24 hours, there is a definitive improvement. But what about less than 12 hours, less than 8 hours, less than 4 hours? And that's what is called as ultra-early threshold surgeries. People have looked at surgeries less than 8 hours, and they found that there's a good improvement at 6 months follow-up in patients who have been operated at less than 8 years. But what is interesting is that in this ultra-early group, if you see the change from Asia A to Asia B, R to C and D is also possible. Therefore, what this extremely ultra-early surgery has shown is that it benefits not only incomplete spinal cord injury, it could also benefit patients with complete spinal cord injury, and also it helps in decreasing the length of stay. This is one of our case examples where patient came in within 1 hour. We were able to operate within 2 hours, and he improved from a grade A to D over a period of 4 weeks. And I would say that I had operated around 5 to 6 patients as early as possible at less than 6 hours, and 4 of them had done extremely well. And this is what various meta-analysis has shown. People have looked at ultra shorter, less than 4 hours, but they've shown that there's no difference in outcome between less than 4 hours to less than 8 hours. And also one more important thing that matters is the intramedullary lesion length. If the lesion length of the cord is more than 2 or 3 vertebrae, it's relatively longer, then the outcome could be poorer. Okay, what about in central cord syndrome? Again, in central cord syndrome, there is evidence to show that early surgery improves the outcome in terms of function of the hand, the paresthesias that tend to happen in central cord syndrome patients. Therefore, earlier is better, even in patients with acute central cord syndrome. But as we all know, early surgery cannot be achieved in majority of our centers because of the facilities of transportation and the expertise of availability of surgeon all the time. And therefore, what is practical in majority of the centers worldwide is less than 24 hours. But whenever it's possible, it's better to operate a spinal cord injured patient as early as they come to realign the spine, to decompress and stabilize so that the chances of improvement is better. To conclude, earlier is better. Less than 8 to 12 hours is what we should look for. Better results in cervical, better results in incomplete injury, and better results also in central cord syndrome. Thank you.
Thank you, sir. Thanks for the nice talk. After the session, we'll have a time for question and answers.
Okay. Sure.
Leave it for that. And now I welcome Dr. H.S. Chabbra, sir, past president of Association of Spine Surgeons of India, to give his talk on stem cell in spinal cord injury. Are we yet there? Over to you, sir.
Thank you, Dr. Guru Raj. After a wonderful talk by Dr. Ajoy Shetty, I'll be covering this controversial topic, just trying to throw light on where we are with regard to stem cell therapy or cellular therapies with regard to spinal cord injury. Every now and then you keep getting such publications in the media where tall claims are made about recovery after stem cell therapy for spinal cord injury. In our country also, there have been various claims, and there is still stem cell therapy or so-called stem cell therapy being practiced in different parts of the country. However, when you look at stalwarts, whether they are from US or whether they were from US or Canada or India, who despite all resources continued to be on the wheelchair, that makes you wonder, are we actually there yet? So to look into why the confusion is, we need to understand the pathology, review cellular therapies, analyze the confounding variables, and try to come to a conclusion. The myelinated fiber tracts of the adult CNS have a complex and regular arrangement of 3 types of glial cells. When a tract is damaged, the cut axons produce local sprouts at the site of injury. But even with minimal disturbance to the tract glial framework, the sprouts do not re-enter into the distal part of the tract. So this has been the main challenge which we have faced in regenerative therapies. So the cell-based approaches to treat spinal cord injury can be grouped into replacement cell therapy or regenerative cell therapy. The objectives of replacement cell therapy are replacement of functional neuronal and glial cells with the aim to regenerate axons and myelination of regenerated axons. So methods used in replacement cell therapy have been several. The stem cells from xenografts have been used, embryonic and fetal stem cells, umbilical cord blood stem cells, and adult stem cells have been used. Let's look at them one by one. Porcine stem cells and embryonic stem cells have been used, but results have not been published. Human fetal spinal cord cells have been used in trials. Only safety of the procedure could be established, and survival of the graft in the host could not be demonstrated. And this is again one of the main challenges as to whether the cells survive or not. Then this Korean trial, we are all aware, even though there were tall claims, the researchers were put to disrepute later as it came out. Adult neural stem cells have been also used, but these have been mainly preclinical trials. No clinical trials have been done. And with adult marrow stem cells, autologous, intravenous, intramedullary, or intraspinal injections have been done. And this has been studied a lot. There have been clinical trials also. We also did a study on autologous bone marrow stem cell transplantation in acute spinal cord injury. And we could conclude only that it is relatively safe and feasible, but no efficacy could be demonstrated. So embryonic stem cell therapy has various advantages. They are pluripotent cells. They do not have the potential to develop into adult human being. They can be transplanted after differentiating stem cells in vitro to the required precursor cell type. But there are risks of immunological rejection and risks of tumor or teratoma formation, risk of mutations, dedifferentiation and transdifferentiation, and risk of infections, non-viability, mutation in stem cells have been there. Adult stem cells may be autologous or allogenic. There is low risk of immune rejection, so no requirement of immunosuppression is there. There is no risk of tumor or teratoma formation as would be there with embryonic stem cells. And there are no major ethical issues as are there with embryonic stem cells. However, they have a limited capacity for self-renewal and differentiation when compared to embryonic stem cells. And you can harvest not a lot of cells as compared to the embryonic stem cell therapy. The greatest challenge in stem cell research has been to uncover the extracellular and intracellular mechanisms that determine and control the self-renewal and differentiation properties of the stem cell in physiological as well as host environment. Hence, preclinical and clinical studies with stem cells are still inconclusive, even though we have a fair outcome with preclinical studies. Regenerative cell therapies have the objective to achieve axonal elongation and regrowth through the adult CNS and to restore myelin around spared and primarily demyelinated axons. And there are various methods which have been used. We'll cover them one by one. There have been clinical trials using peripheral nerve grafts, though efficacy could not be demonstrated with them, even though they have been used from a long time. Schwann cell transplants increased sprouting in the corticospinal tract, but very few sprouts entered the distal tract, so there were no efficacy demonstrated. Activated macrophages also, there were phase 1 and phase 2 trials, but unfortunately, they have not been reported as yet in the literature. So the major problems in regenerative therapy for spinal cord injury has been that the axon sprouts were reluctant to leave the Schwann cell environment of the transplant and re-enter the glial environment of the distal corticospinal tract. Olfactory ensheathing glial cells have been studied also vastly because of continuous physiological mechanism of regeneration and reconnection occurring between the peripheral nervous system and central nervous system, especially in the olfactory region. And so it was thought that if you could take the whole olfactory mucosa from the region and transplant that, it may recreate the same environment and you may have good results. This is the only example in the body where the peripheral nervous system goes into the central nervous system. So Carlos Lima published this study claiming good results with autologous olfactory mucosal autograft, and there were a lot of patients who came even from the US to undergo this treatment. But when we did the same study, properly planned, observed by an international steering committee and under the aegis of the ICMR, controlling all confounding factors, we could demonstrate that it is only safe and feasible, but we could not demonstrate any efficacy of this procedure. So there have been, even though there has been preclinical evidence of usefulness of cellular therapies or stem cell therapy, there have not been many clinical studies, and none of them have been able to demonstrate any efficacy in this regard. And our literature review also demonstrated in this regard. So the problem is that the results are too fast for regeneration, as claimed by the people. Therefore, the mechanism for early recovery is not known, and nobody has been able to exactly tell how their transplant has worked. However, the claims of success through the media about spinal cord injury management with cellular therapy have not been backed by trials, and this causes a lot of stress on the patients, and they do not go into the proper established standard of care, that is rehabilitation treatment. If you look at the various factors which discriminate patient outcomes, there are plenty, and it only points out that there is a need for a proper clinical trials which are well conducted. We know that there is a natural progression of SCI in all incomplete cases. Also, in complete cases, they may have recovery in the zone of partial preservation, and that this recovery could continue even up to 400 days after the injury. And we also know about the subject bias, the placebo effect, which may confound the outcomes, the observer bias, which may confound the outcomes, and there may be improvement because of the plasticity of spinal cord, which gets harnessed by the augmented physical therapy after a trial. And we also know that there can be effects of delayed decompression. So, as I talked about, the patients get affected and do not pursue the standard of care. And we also are aware about the adverse effects of cellular therapies which may be there. There are plenty, but there are also autoimmune effects which may also prevent any subsequent successful therapy which may come. So it may prevent the patient from reaping the benefits of that. And so there have been various concerns about stem cell therapy being practiced without proper regulations. And our position statement pointed out the need for coming out with regulations to control unethical practices in this regard. And we know that there are proper documented ways in which such trials can be practiced. The guidelines for the conduct of clinical trials for spinal cord injury are published, and a good trial needs to follow these. So if we were to look into the carry-home message, the list of experimental therapies that have been developed in animal models to improve functional outcomes after SCI is extensive. Though preclinical trials have shown a good potential for cellular therapies in SCI, there is no documentary proof that any form of cellular therapy has a definite role in management of human SCI. The adverse effects of many such therapies are well documented. Thus, there is a need to conduct proper clinical trials. Some early stage SCI clinical trials have recently been started. However, some experimental therapies have been introduced into clinical practice without a clinical trial being completed. Undue hype by the media and claims by professionals have a profound psychological effect on the spinal cord injured and interferes in the rehabilitation, and this should definitely be curtailed. I thank you for your patience and would be happy to answer any questions subsequently.
Thank you, sir. Thank you for giving that elaborative talk on stem cells. And most of it is new for most of us here, and thanks for that. So we'll move on to the next talk by President of Bangladesh Spine Society, that is Dr. Shah Alam. So, sir is going to talk on, do all spinal injuries need decompression, or is there any role of decompression in spinal cord injury patient?
Thank you, Guru, and your team. Guru, can you see me?
Yes, sir. We can see. We can, but then put it on a slideshow.
Slideshow. Yes. No, slideshow.
It's not on slideshow. We have to hide the next slide or notes.
I think, sir, you have to log off and log in. If it doesn't happen with this, you have to log off and log in, sir.
No, I think that's fine. If you If
No.
you,
From my side,
if
it
you,
is not Guru.
Yes, sir.
I'm not sure our side when I do, but it comes all of you. I don't know.
So
on
that's
top,
so
on
when you
top, if
when
you
that
can remove
happens,
show taskbar, remove show taskbar, and then just
Yeah.
click on show taskbar, and then it will come like that.
Right.
On the left side, show taskbar.
Yeah. Now click on the
This is-
slideshow.
Slideshow down, sir.
Okay, okay.
Down.
I'm good.
Slideshow down there.
Yes.
Yeah.
Yeah.
No.
No.
When I press slideshow down, it comes this size.
but if you unless you log off and log in, this will not solve.
Okay.
This is
Log
like-
off completely, you mean?
You log off from Zoom and log in back, or
Oh,
unshare
Guru,
and reshare. Unshare
let
and
it go.
reshare.
Guru,
Stop
let
sharing.
let her continue.
Okay. So, Dr. Shah Alam, you can go
Yeah.
back to your PowerPoint mode, and then we can continue on that slide.
Okay.
Not this. The show taskbar again. Yeah, we can maybe go on this screen.
Okay. Should I proceed?
Yes, sir.
Okay. Thank you, Guru and your team, and also thanks to ASSI by the collaboration with the Bangladesh Spine Society. So my talk on thoraco-lumbar trauma in general, but mostly my concentration to all spinal injuries need decompression. So this is the one of the scenario, the burst fracture, the whole canal is compromised and a lot of fragments. So I will share our experience after the discussion of all presenter and case presentations. What would be the classification and what would be the treatment and what level of fixation, compression, decompression or not. But this is my workplace where I am working, and it's a collaboration of the India and Bangladesh. So what is the principle of decision making in burst fracture of the thoracolumbar and lumbar spine? The first is the decompression of the neural tissue and stabilization and fusion. So how to, decompress? The proposed surgical treatment strategies are maybe the direct or indirect. So when we do the indirect, the decompression by doing the ligamento-taxis, and when we do the direct, maybe the transpedicular decompression, or we can remove the whole fragments, lamina, and the whole, the fragment that compressing, so we can decompress the canal as well as the foramen. So what is the necessity of direct decompression of thoracolumbar junction or burst fracture with neurological compromises? If we see the literature, it is seen that in many literature, basically there is no differences in outcome when direct decompression or ligamento-taxis. Again, if we see the other, the paper, they have shown that the clinical results of posterior stabilization without decompression for thoracolumbar burst fracture is a decompression necessary, and it is seen that the no decompression in direct or indirect or even in the presence of the reverse cortical signs, there is no difference. So when it is the neurologically, the deficit, the direct association with the severity of the initial canal damage and neurological deficit, still it is unknown. That's why the question comes, is there any correlation between the neurological deficit and spinal canal compromises? There is a data analysis of 198 patients with thoracolumbar and lumbar fracture. It is said that yes, there is a positive correlation between the spinal canal compromise and the severity of incomplete neurological deficit. But it is still unexplained, that unable to explain why the Frankel E patients and Frankel A patients are presented with similar narrowing of the spinal canal. That's why the neurological injury in thoracolumbar burst fracture question arises. So no significant correlation between bony or canal disruption of the with neurological deficit. But of course, there is a significant correlation between the energy of the injury and subsequent the neurological status. That means that every chance to deterioration if the magnitude of trauma is very high, initially if it occurs. So how the spontaneous canal remodeling occurs? If we see here, there is a provision that the progressive remodeling occurs during the first 12 months after injury. Even the retrobus bone that is shrank about 1/3 of the initial size within 12 months. If we see these the axial section of CT scan, the immediately after injury and 2 weeks after injury and 12 months, there is a huge, the recanalization of the canal, and the bony fragments in the canal usually do not represent the continuation or the continuing the progressive, the neurological deficit or the compressive force working over the spinal cord or not. So the neurological starts when neurological recovery starts. It is seen that it starts even the before surgery. So immediately after, the injury, naturally it occurs, it starts or it tries to recover the neurological function. So the surgical canal clearance does not affect the extent of the neurological deficit. It is there's a lot of paper supporting that. So recovery of the bladder function and other is little bit different. It is dependent on the sensory disturbance of the perianal area at the time of injury. But it is totally independent of the treatment method, because the treatment, whatever the way we do, and initial the sensory deficit if it is, so there is some differences. That's why the no correlation between the canal compromise and neurological deficit at the time of injury. But the neurological recovery and spinal canal compromise at the time of injury, there is some correlation. But what we do in our perspective, basically we do the direct decompression when there is a reverse cortical sign and when there is the laminar split sign, or if the motor deficit is 3 or more than 3, less than 3, more than 3, then we go for the direct decompression. Again, what is the reverse cortical sign? All of you know that this is the fragment coming from the posterior wall, and when it is flipped 180 degree or more than 180 degree with the cancellous surface facing the canal, in that case, ligamentaxis is basically contraindicated. That's because the all PLL is ruptured. That's why there is no issue if we do the ligamentaxis. But there is other, side, that is the pseudo reverse cortical side. It means when this rotation is less than 90 degree, not 180 degree. In that case, there is some compromise, but it is not like that of your reverse cortical sign. But here, the ligamentaxis has some growth, because to some extent the PLL is intact. For an example, this is the first one I've shown this. If we see that after the reduction and the stabilization without any decompression, if we see the initial, the sagittal section here, the canal totally was compromised. But when you see here, the canal is almost the good spaces there. And that is the issue, that no need to do all the time, the decompression. So another patient having with the ASSI, L1 bursa fracture. This is before surgery X-ray and CT scan and also MRI. And the last one is the X-ray, the good, the height regaining and without, the decompression, just stabilization alone, and ligamentaxis was done. Another patient, the ASSI neurology, the burst fracture, if we see that there is a 20-degree kyphotic angle, and without any decompression, when we stabilized posteriorly and we did the ligamentaxis and the good regaining of, regaining and only the few degrees of kyphotic deformity is there. This is another patient with the ASSI, only few degrees existing. The kyphosis initially was 28 degree, and this is the 10 degree. And if we see this young boy that totally has regained his neurological function and can walk and can stand and walk, but we didn't do any sort of the posterior decompression only, but no, only stabilization, no neurological, no decompression was done. This is another patient in the junction of the D12 and L1, the ASSI. We did the posterior surgery, and also we did not decompress, just only stabilize. And this is the the post-op CT scan. And another patient, this is the bursa fracture at D11 and D12, the ASSI. So we didn't do any decompression, only the stabilization, and we did it by the MIS technique, so no need to open. The another patient, the L1 burst fracture, ASSI injury, and it was stabilized only by doing the posterior stabilization, no decompression. So we see that in our case, the 49th patient we did, And our series was starting from January 2018 to September 2003. And it was done in the Spinal and Orthopaedic Hospital. And the injury starting was from 5 to 20 days, and minimum follow-up was 3 months. So in our series, we've seen that the 25 patient regained the neurology at the first follow-up time, and the mean pre-operative kyphotic deformity was about 27, and it was G2 10. And ODI improved up from a pre-operative score 67.2 to the final, the 25. So the final, we like to say that when there is no deficit, no decompression, ligament taxis can be done in most cases and is as effective as direct decompression. So the careful patient selection might avoid the direct decompression as well as save the operating time. Thank you for your kind attention.
Thank you, Dr. Shah Alam. Now the session is open for discussion. Do you have any questions?
Dr. Guru?
Yes, Dr. Ranjit.
Yeah, can I have a question to Dr. Ajoy Shetty, sir? Sir,
Yeah.
you said about the ultra short window of surgery and
Yeah.
the advantage where people you noticed as difference in the Asia grade. So in advocating ultra short window surgery, aren't you operating on more patients with spinal shock?
Yeah, that's also a fact, because you might consider saying that a patient with a spinal shock is going to improve. But having said that, how many patients with Asia A you see them recover without doing intervention? If you have to compare that group of people with the operation within 8 hours or without greater than 8 hours, it's always a point that when you are operating with less than 12 hours, you might say that probably the patient were in spinal shock, they might have recovered. That's always a point. I mean, we cannot 100% say no.
Yes, so probably in a type C, it doesn't make a difference. You know that it is seldom important. So in a A3 or a A4, in a burst situation where we really, so at those situations, you give importance to the structural damage than the cord injury, right?
It's basically better in cervical. Thoracic, whenever there is a AO type C injury, the disruption is so much, they are less likely to improve. Basically, in situation where there is a static or a dynamic ongoing compression, it could be beneficial.
Thank you, sir.
Yes, sir. Sir, Chabbra, sir.
Yeah, I would only try to carry it forward from what Ranjit has mentioned. If we look into the literature, Middendorf had written a letter to the editor, to the Spine Journal, and had pointed out various shortcomings of the Staskis trial, and so if you would talk to Mr. Masri or Middendorf, they will talk about how the data has been misinterpreted. Also, because as Ranjit mentioned, the real outcome gets known at 48 hours since the injury. So many people who are claimed to be Asia A may not actually be AIS A, because at 48 hours since the injury, they will be AIS B or C. So today, even today, that debate continues. Even in the recent ISICON, there was a pitched fight between Mr. Masri and Dr. Michael Felix, and we'll be coming out with a virtual special issue in JCOT, which will cover the conservative versus surgical management of vertebral fractures. So there are claims, but there are counterclaims as well, and we can't ignore them, Ajoy.
Sir,
I will just add one sentence. I agree with Dr. Chabbra. What I have heard is that they came out with the Stasis trial basically because majority of this polytrauma centers, the government was trying to shut down it, and they had to show evidence that there is a benefit of operating early. I mean, there's always in US, when it comes out from Northern America, you have to be very cautious. How do you interpret that?
Okay. Also, Ajoy, we have to see that not many centers in India may have the same facilities of anesthetic and perioperative management as centers in developed countries have. And we know that if we do not manage the patients well during surgery, it may adversely affect the outcomes.
Maybe, yes.
So I have a question to Dr. Ajoy Shetty, sir.
Sure.
Can I ask?
Yep.
So in our perspective, we have observed in particularly complete cervical spine injury. Suppose a patient in our perspective, a patient come to late, so maybe a case of 6-7 dislocation or like that. As we have observed that maybe whenever the patient respiratory center is involved, although it is a 6-7, suppose after injury time is, if it is a day 4th or day 5th, at that time patient has respiratory distress, severe respiratory distress. So in that scenario, do you advocate to operate this patient, and what will be the outcome of this patient? And another thing is that even a patient is normal neurology, I mean the ACIA initially is okay, but what we actually observe just after operation, maybe 4th or 5th post-operative day, patient has suddenly deteriorated. So what is the reason behind that? And what is your observation?
Basically, for the question number 1, is there any benefit in operating somebody who comes after 4 days with respiratory distress? Usually the benefit is very, very less. I mean, especially in a country like ours, the expenditure the patient has to incur, he will go on a ventilator. The outcome is really poor. But for us, we can't make the decision. We have to discuss with the patient, the family members, the benefits, pros and cons. And usually what happens is that the family members feel that they have to do what is right. And they usually, pressurize us to do a surgery. The outcome may be poor. Coming to the fact why some patients deteriorate is probably the edema. Post-intervention, there could be an increase in the edema, which can extend proximally, might involve the
ascending
upper
hematoma. Could be ascending hematoma also.
Yes.
Ascending edema.
Hematoma. So I have a question to Chabbra, sir. Sir, you gave the current statement that as of now, stem cell therapy is in a research stage. We cannot advocate it to patients for a charge or for a money because it is still experimental. So as a surgeon, is there anything which I should take care when I operate so that a future stem cell therapy is possible in that patient? Any surgical things which I should take care when I operate a patient of thoraco-lumbar trauma or a cervical spine trauma?
So that is also a difficult question to answer because if we say do a decompression so that you have a patent canal, so that any subsequent successful therapy, you have a patent canal there. But the advocates against this would say that there is remodeling which can happen, as also Dr. Shah Alam pointed that out. And most of this compression gets resolved with time. But of course, we can reduce the chance of syringe. So whether direct or indirect decompression, if we can achieve that, most of the cases you can achieve indirect decompression, and that is what we try to achieve in this patient, so that subsequently it is possible that they get the advantages of any successful therapy that may come. Other than that, I am not aware because of any other surgical interventions which may help in a successful therapy subsequently. Carlos Lima used to decompress even the cord by opening the dura and removing any adhesions. But as we found out subsequently, it can be counterproductive as well.
Chabbra.
Can I ask one question?
Chabbra.
Yeah, sure.
Chabbra.
Yeah.
Can you hear me? I have one query to you. One thing is that, so, in your observation, when you are using stem cells, say the cervical, dorsal, upper dorsal, lower dorsal, is there any, the correlation, the which part of the spinal cord responded as a better by putting the stem cell?
I can answer that in you can document the outcomes better in a cervical spine injury, because even if there is one root recovery, you can demonstrate that. Whereas in a thoraco-lumbar or thoracic level injury, you have to have recovery at multiple levels before you can document. So we are trying to come out with objective outcome assessments so that we can document recovery through EMG and other methods. There's an Indo-Swiss study which is going on at the moment in which we are participating, which may come out with this. But the con there is that the potential harmful effects of intervening in the cervical spine are far more than in a thoracic spine. So we need to draw a fine balance when we choose which areas of the spine we go. Generally, it is recommended that we should try first in the thoracic spine because the potential to harm there is much less than in the cervical spine.
Thank you.
Also in an era where there are other better experimental techniques which are available to give benefit to the patient, like epidural stimulation. So I would say it may be totally unethical to put the patients to, I would not say therapy, I would say stem cell transplantation, other than in a proper trial where you are more positive about the outcomes which have been documented in a preclinical study.
Okay, thank you, sir. For want of time, last question from Dr. Shahidul Islam, and then we'll move on to case discussion.
Thank you very much, Guru, for giving me the opportunity. Thank you very much, Professor Dr. Shah Alam, President, Bangladesh Spine Society, for your brilliant presentations. What message you want to give when there is a lamina split sign for direct and indirect decompression for our juniors?
Yeah, the linear split sign and reverse cortical sign, when there is that, then we advocate for decompression and stabilization. It means that only stabilization is sufficient when there is no, I mean, the laminar split sign, there is no cortical, reverse cortical sign, or even pseudo cortical sign. In that case, only stabilization is okay. So when these are the signs, or with a neurological deficit, then in that case, definitely we'll do decompression.
Okay, thank you. So next we'll move on to case discussions. If all the faculties agree, there was a slight change in the plan because as my co-moderator, Dr. Ranjit, had put it on the group. So we'll start with the case which is without neurological deficits. So that will be presented by Dr. Junaid. If everybody agrees, we'll take that case first and then we'll move on to other more severe fractures.
Okay.
Okay. So Dr. Junaid, can we start with your case discussion, please? Dr. Junaid, are you there? Okay, so I think
Yeah.
Junaid, go on.
Okay.
Okay, can we have slide show?
Yes. Let me look. Okay.
Yeah. Thank you.
So, am I audible?
Yes.
So, thank you, Dr. Guru. So, as it is a thoraco-lumbar session, so we will start our case. So basically, this is my case and I have nothing to disclose. So this is the patient with 30 years female. She is a housewife with a history of fall. And she presented with severe low back pain 2 days after injury to the emergency department. And she was got admitted in spine unit of our hospital. And in examination, it seems that her neurology is almost normal and there is no bowel bladder involvement. So things is that there is a already 48 hours since injury with a history of fall with normal neurology and intact bowel bladder involvement. So this is the X-ray of the patient. So anybody from the panel comment on this?
So Dr. Sahil, Dr. Sahil, can we have your comment, please? Can I hear?
You should go ahead. Okay, so Junaid,
Yes.
from this, I know, I kind of think that there's a burst. There's goes to a A3 or a A4 for me. So
Okay.
I need to have further imaging. I need CT and MRI to prioritize this.
Okay, fine.
But it looks more like a translational injury disease.
So this is the CT scan. You can see that. So only the the lumbar tree fracture with severe comminution, with posterior band is almost intact.
So this
And
is A4 for me. This is A4.
A4, yes, because
Yes.
there is the both end plate fracture. You can see here, right? And there is also the posterior fracture as well as the retropulsion of the canal. And this is the MRI. You can see that the thecal sac is, the indentation with compressed by the fragment. So this patient, although there is a severe compression, but fortunately she has intact neurology. So based on this CT, X-ray and MRI, what to do? So should we treat it conservative or should we treat it by operation?
Dr. Anwar? Dr. Anwar?
Yes,
She has
yes,
a no-
Dr. Guru.
Yeah.
Yes,
Yes.
Guru.
Yeah, you
Uh,
can.
As it is A4 type of fracture and vertebral height is not maintained properly, definitely I should go for the decompression by corpectomy and fusion by mesh cage with bone graft with stabilization from the pedicle screw and rod. I think that will be better.
So is there anybody differ?
Yeah,
So-
I differ.
Yeah, Ranjit. Go on.
I'll go posterior. I'll do about two below screws and one index screw, and I'll give time to heal. Because in this I just want to stabilize the spine. I don't want decompression because her neurology is normal.
Okay.
I just want to treat the stability, the bony instability. I'll just do a posterior surgery. I'll not touch anterior now, telling the patient that if it fails in future, I'll go anterior anytime. She's a young lady. I don't want to violate her abdomen.
And
Okay, I want to.
also can see intact. Say posterior ligamentous complex is okay. So I am in favor only the posterior stabilization.
Okay. Dr. Chabbra?
Yeah, I believe this is a young lady, right? Correct me if I got it wrong.
It's a 30-year-old lady, sir.
Right, and we in an era where we talk about sagittal balance, this is a lying down X-ray, right, or an MRI, right? If we were ever to get a standing X-ray, there would be gross, the sagittal balance would be grossly affected. There is, we can see that at least two of the lines, the anterior vertebral and the posterior vertebral line, are grossly affected, and I suspect that the interspinous line would be also affected. So I think this is a 3-column injury.
Yes.
I would not go 2 above and 2 below because I want to preserve segments. So I would go 1 level above, 1 level below, put a screw on one side in the affected vertebra, a short screw. From the other side, I will, from posterior only, do a corpectomy, partial corpectomy, and put in a cage in front. And in my experience, that should promise a good outcome in this young lady.
So let me correct myself. I meant 2 screws above, 2 screws below. One segment above, one segment below. Index
And
screw.
also the index screw.
Index screw, yes.
If we were to put both the index screws and correct this deformity, then they are likely to fail because it will open up, right? And a lot of stress will come on the implant. So as soon as you correct that. So you need to put an anterior support, which you can put from one side, not with the intention of decompression, but with the intention of
Reconstruction.
and at this level, doing that is very easy because you have only the cauda equina there, and there are very less chances of injury. You can easily do it from behind.
So if I may ask, sir, in this patient, what will be our aim ultimately, what we want to achieve at the end of our surgery?
A stable spine with a long-term sagittal balance being maintained, because we want to prevent late complications of pain in this patient, because late intervention will be much more complicated. And at this moment, we have an unstable spine where the sagittal balance can be corrected very easily.
Okay. Dr. Ajay, I know in your center, you routinely take out implants after some time. So would you differ?
I do not always.
Yes, sir.
I do not remove the implant. Most of the patients who have these fractures are very poor. Even if you suggest, they would not come back.
Yeah.
But in the situation, sometimes when we need to put a long segment in the lumbar spine, after maybe around 9 to 10 months, I would prefer to do the removal so that the mobility at the other ends could be there.
Sir,
not always.
Sir, so when you plan to remove, already you have planned to remove the implants, will your plan change in such kind of patients?
Not in this patient. This patient is the one we definitely need to have a better stability and fusion.
Okay.
Even if when you look at the X-ray, you can realize the kyphosis is greater than 25 to 30 degrees. That usually implies, irrespective of whatever you see in the X-ray, CT and MR, that the PLC has to be disrupted. I mean, there is a significant injury for this patient.
Yes.
I mean, we need something which will allow fusion to happen, either by a combined approach or by a posterior approach. And I would prefer to leave the implant.
So,
okay.
So in that particular case, so you would fix only from posterior, right?
Yeah, I would prefer a posterior approach, like how Ranjit said.
So no corpectomy or like that. So
it's an approach. I'm not saying one is superior over the other. It depends upon when you position the patient prone, how your vertebral body looks like, and whether you'll be able to put the screw. A lot of factors you need to take into consideration.
Okay.
So Ajay, do you suggest any anterior support for this patient? No.
Usually we do not, but I know Dr. Chabbra has published a publication in, I think, Global Spine Journal with regards to a fusion, which he described for lumbar fractures.
I think this is a fresh case, no neurological deficit, posterior ligamentous complex is okay. When we will put in position and lordosis will, regain something. And in that case, anterior support, in our perspective, we don't do, we all do posterior.
It will remodel and
it remodels automatically, because, and also this is in the not, the cord level, in the lower level. So there is a space even, and still there is a chance to remodeling.
Okay. So Junaid, can we go ahead and see what you did?
Yes. Just a minute. So in our perspective, what I actually did, so we did as it is a lumbar vertebra, so we want to preserve the motion segment, and the fracture as it is severely comminuted.
Okay.
So I think if I do the posterior, maybe 1 level or 2 level, ultimately this may be chances of failure, because there are lots of literature suggesting that only posterior can fail these sorts of cases. So what we actually did, we did all from posterior, did corpectomy, putting a case with anterior reconstruction, and this is the the perioperative picture as you have seen, and this is the final outcome. And patient is ultimately very well, and still for it's 2 years already is follow-up, and it seems she's good, quite okay.
Guru.
Yes, sir.
Guru, I think this is the good judgment by the Dr. Sharif Ahmed Junaid, because the anterior column support was very minimum. And the body was fragmented and multi-segmented, so that in that position, if you don't putting the start support from the anterior or middle column, then further recapitulation will be happen if whenever it fixes from the posterior, whatever may be the thing. For prevention of this kyphosis, definitely go for the start graft to maintain the lordosis of the lumbar spine.
Dr. Junaid, can I ask a question to you?
Sure.
I have a question. So my argument to this is that I can do the same procedure with the index screw, and if my surgery, if it fails late, the anterior column fails, I can do the surgery anytime later. I can go from the same back itself. So what do I lose, by giving her a chance to naturally remodel, and probably late down the lane, if I see the column is going for kyphosis or screws loosening, I can go in and do the same thing from the back itself.
So I am totally agree with you, but the problem is that in our perspective, suppose the doing surgery 2 times, sometimes it is not allowed by the patient. He or she maybe it is not feasible for his or him to bear the expenses of the surgery.
She or he will not be agreed. She or he will not be agreed for the second
That's why if we want to a very rigid construct, and ultimately here with a on anterior support with a very good strong and rigid construct and with a very good outcome.
Okay, so the last comments from Dr. Chabbra sir, and then we'll move to the next case.
Yeah, Ranjit, my only point is that we should not lose the opportunity to be able to get a good sagittal balance at the first go. In this spine, in the acute phase, it is much easier to put in a cage in front from behind than in a fused spine, where the chances of complications also become more. And I find this procedure very easy, where you remove the pedicle from one side and put in a cage from one side. You don't need to go from both the sides in this patient. And so I would not want to lose the opportunity, but I agree that there are various ways of trying to achieve the same outcomes. So
very well done, Dr. Junaid. Do you have any take-home message on this? Or
yes.
Kindly.
So in take-home message is that single posterior approach is a safe, cost-effective, as well as the reliable surgical procedure for reconstruction of all the columns of the spine. It reduces the operative time, blood loss, and morbidity associated with the combined approach. For this particular case, though it is neurologically intact, but as it is very unstable fracture, so in that case, I mean the operative treatment with anterior reconstruction, our main aim is to construct a rigid construct so that we can offer her a single surgery that can attain a maximum outcome. Because if we want to do only posterior, either maybe short or long segment, so eventually there may be still chances of failure. So it may not be feasible for her to bear the second surgery. So that is the message for our perspective. But that in opinion may be differed, but in our perspective, I think that's a very good approach, even in spite of a intact neurological. So sometimes A4 fracture, as it is a very unstable fracture, it should be stabilized. So that's my message.
Okay. Thank you.
Guru, any scope to further
question to Junaid.
Yes.
To introduce a case in posteriorly,
yes,
is it very easy to introduce? Is a long case, in particular in this area.
Yes, I am agreed with it, but we are doing these sorts of surgery very frequently, though there are controversy regarding the anterior column support or not, but as we are doing regularly, so we are very much accustomed. So it seems for lumbar, I think though it is as it is needed, there is a valuable route, so it should be done very cautiously. But as we are doing regularly, so I think we are now almost familiar with this. And as already Dr. Chabbra has mentioned,
Guru, any scope to question, further question? Guru,
Dr. Ekon, I think we are running out of time.
Yes.
We can maybe we'll involve next case. So we'll move on to the next case. Before moving on, we would like to just say that this kind of fractures, definitely you can do it all the approaches, combined approach, maybe only posterior. Some people might manage them with only anterior approaches also. So the lumbar fractures are totally different as compared to thoracolumbar fractures. So you just need to have the good sagittal balance, achieve a stable spine, and ultimately a fused spine. So that is what is the aim of surgery in these kind of patients. Thank you, Dr. Junaid. Can you just okay? Now I would like to ask Dr. Syed Shahidul Islam, sir, to present his case because he's going to present on a case which is in continuum to what Dr. Junaid presented. Sir, you are muted.
Unmute.
Dr. Islam, you are muted.
So by the time sir is logging in, so
Yeah.
Dr. Kamrul, today, so we have moved over and we do the same thing, but by a OLIF axis. We do the posterior MIS screw and do the corpectomy by OLIF, and the struggle of pulling the root, pushing the root. I've given up that now. When I do it now, same sitting, lateral screws and oblique approach, OLIF approach, corpectomy. So the struggle, same thing, but achieved MIS way.
MIS. Good.
Over to you, sir. Professor Islam, over to you.
Okay, can I start now?
Sure, sir. Please go ahead.
Thank you, dear moderators and the presenters, as well as other faculties, for giving me the opportunity for this case discussion. So this patient came to our emergency department. This is a 37-year-old male patient, had road traffic accident, and came to the emergency department with back pain, and he has ASSI neurology. And doing this X-ray, we found there is a fracture at the lumbar 1 vertebra. And to see the morphology better, we did the CT scan. We found this one. And what to do next? Dr. Anarul Islam, please.
Thank you, sir, for asking me the question. I'd like to do a MRI of the lumbar spine and screening whole spine. Because
yes, definitely,
MRI,
because the
MRI
person has...
Yes, MRI sagittal and axial section, I'd like to see how much the retropulse fragments, or is there any compression over the conus medullaris or not. I would like to see that by the MRI. Then
so to me, seeing this lateral view of the CT scan, there is a increased distance between the
interspinous species increase. PLC is not intact.
So I suspect a posterior ligament complex injury because clinically it was not evident, and X-ray there is no gap between the spinous process, but as there is a gap between the spinous process and CT scan, I did the MRI also, and this is the MRI.
Yes.
And definitely you can see here is the PLC injury.
Yes.
And now what to do for this patient? Sorry, I have no axial section. I have not put it that.
Whatever may be the axial section.
Anybody other than Anar, please?
So for me, if I can answer, for me, it is again posterior surgery. I'll put one segment above, one segment below, index screws, and I will put it MIS. I will not do it open.
Thank you very much.
I do agree with Dr. Ranjit for this particular case.
Dr. Ranjit, so I have a query regarding this. As the patient is already ASSI, so in that particular case,
ASSI.
No, it is not ASSI.
Yes, ASSI.
So do you still consider MIS for this patient?
Definitely yes. Definitely yes. For me, unless the CT is showing more than 60-70% of canal compromise, I will not touch the canal. Because for me, this is a it's a vicarious canal. It's already contused. The dura is stretched. Maybe my bit torn also. I go in and decompress. It is improved beyond doubt that it doesn't add to my neurologic recovery. In this, I have to get all the sagittal parameters right. Get the column, get the cardiac kyphosis, give stability, and indirectly decompose the canal, which I can sure get with the ligamento-taxis because the patient has come in fresh. There is no reverse cortical sign.
So I have a query regarding this because as our previous speaker, Professor Dr. Shah Alam sir, has mentioned that only the split laminar sign is probably the only indication for decompression. But in our perspective, suppose this patient has already presented with ASSI with bowel bladder involvement. So in that case,
no bowel bladder involvement. ASSI, no bowel bladder involvement.
Only ASSI neurology.
Chabbra sir,
Chabbra sir want to say something.
Yeah. Okay. See, I would definitely try to achieve decompression, but I would try to achieve an indirect decompression.
Right.
And I am almost sure that I should be able to achieve that as soon as I position the patient. Then how you put in the index screws also determines how you achieve decompression. So I would put the index screws in the line of the pedicles, right? So that when I put in the rod, the vertebral body gets corrected, the kyphosis, local kyphosis gets corrected, and decompression is achieved in that patient. So even otherwise, an AISC should recover most probably to AISE, but I should be able to get an indirect decompression. But I would differ from Ranjit in that I will use 6 screws. If the patient is very bulky, I may use 8 screws. Means I will use the index vertebra screws. I will go 1 level below, 1 level above, and if the patient is very bulky, 2 level above. But I will put in a peak cage, right, from one side, because the disc is involved. If you see the MRI, the disc is grossly involved. And if you do not put in a support there, the disc will certainly collapse with time. All right, and all the stress will come on the implant, and that may fail. So there is no harm in going in from one side, putting in a peak cage there, which would act like an anterior support. So 6 screws, peak cage, indirect decompression, follow up the patient in the MRI, most probably post-op screening MRI, I would have achieved good decompression. If the patient does not improve subsequently, right, does not continue to improve, you can always do a direct decompression later. How this differs from where the previous case is, this is at the cord level. Yes. The chances of deterioration with aggressive direct decompression are more, especially when the cord is injured. And so I would try to be a bit conservative in this case.
So 2 questions, sir. How do you put in you go a transfacetal access to put in the cage?
Yeah, either transfacetal, actually you can go extrafacetal also, remove the disc and put in a cage without affecting the facet.
So the cage will span from the upper end plate of the lower end plate of the upper vertebra into the body or into the...
No, not in the body.
Not
only
body.
in the disc space.
In between the disc space.
Only in the disc.
L1.
My question is...
Part of the end plate is preserved, not the full end plate is affected.
Another question, so do you always get a post-operative MRI in all your traumatic spines?
I always generally try to get, unless the patient can't afford it. Screening MRI costs only 3,500 rupees.
It's not about money, sir. Money is irrespective of money.
Yeah.
So, okay.
I want to document
okay.
post-operative, what is the amount of decompression I have achieved.
Dr. Ajoy, do you get it done, sir, in your center? Because in the high...
Ranjit.
Yes, sir.
What we do in our perspective that I always try to use the fracture vertebra, and this is a junction at a L1 level. I would like to provide the stronger, span, two level above and 2 level
and 2 level below. Yes, definitely. I also support you.
It will provide the stronger support. On L1, the junctional. So short segment, to me and our observation many times it fails. So in that case, definitely we are all the time practicing the fracture vertebra in the index vertebra. Both sides I stabilize and also 2 above and 2 below. And that provides an excellent result.
Interesting.
Basically, it shows that there are many options.
Shah Alam, will you do it by means or open?
No.
Dr. Kamrul,
you can do MIS, MIS, and also ligament laxity sufficient if it is a fresh case.
Dr. Ajoy, do you get a post-op MRI done all your traumatic spines like Professor Chabbra? No. Excellent.
Ajoy, what do you want to do for this patient?
My approach is like Ranjit explained, but I would, I'm not a MIS guy. I do MIS fixations, but for me, the principle is the same. You do 1 screw above, one above, 1 below.
Index.
Index
on index
vertebra,
group.
I will do
static
index.
and correct the deformity.
Professor Gururaj?
On index group.
No, I just wanted to have a comment. Like, whoever wants to comment, let's raise the hand so that we don't overlap. So that's all was my request. And I think if we are done with the questions, let's see what was done.
Yes.
Short segment.
Okay.
Short segment with
Yes,
index.
short segment.
Not only short segment including fracture vertebra.
With
and
index
not
group.
one single screw. I use single screw because it is done in 2018. And when Chinese patient came to Bangladesh in our spine society conference, he shows many cases of giving single screw in index vertebra. He was interested, and I put this index screw in this patient. And this was the indications that this was a B2 fracture with the intact pedicle. What I want to achieve already has been discussed. We want to preserve the motion, and there are many literature support in favor of short segment fixation includes fracture vertebra. You see there, this is the X-ray, postoperative X-ray. I don't have any postoperative MRI or CT scan, and see the movement of the patient. I want to show, very interested to show the movement of the patient. That's why I put this video in front of you. This is the 37-year-old worker, is a day laborer. And you see, this is the vertebra. Chabbra was saying about the disc injury in this area. You see the disc space. This is 18-month follow-up. The patient is quite well, and after 2 years, he's not returning back to me.
Okay. Thank you. So that's your last slide, sir?
No. I have to give this support. This is the paper given by Ajoy Shetty was there, Raja Shekhar and Rishi Khanna. And they said that reduction of unstable thoracolumbar spine injury, even with load sharing classification 7, can be achieved and maintained with the use of short segment pedicle screw fixation, including the fracture vertebra, avoiding the need for anterior reconstruction.
Okay.
Thank you, sir. Yes, I will invite Dr. Gururaj to start his presentation on levels of fixation in thoracolumbar fractures. I think we have set the ground with the 2 cases and the discussions wherein we want to go short segment, long segment. Professor Shah Alam want to go long segment. I want to go short segment. So over to you, Dr. Gururaj, to give your presentation.
Dr. Shahidul, can you unshare screen?
Your screen.
Can you unshare your screen?
Stop sharing, rather.
Yeah. Stop sharing.
Yeah.
Okay, thank you very much.
Okay,
So let me share my screen. Okay. Can you see my screen?
Yes, Professor. Yeah. Go ahead.
Okay. So, as very well said by Dr. Ranjit, we were already discussing about whether we do short segment, long segment, or intermediary screws. Let's see in which situation we do what. Basically, there are multiple options. So always, whenever we see such kind of fractures, we are at the crossroads. What to do? Whether we do long segment, whether we do short segment. What are the indications? So we already discussed this. Whenever there is an involvement of all 3 columns, which causes instability, which can cause progressive neurological deficits, which can cause a significant kyphosis more than 30 degrees, and if there is a canal compromise in the presence of neurological deficits. So aims of the surgery, as we were already discussing, to achieve a good alignment according to the area of the spine and good stability, kyphosis correction, and a direct or indirect decompression and functional outcomes or a pain reduction. So once we decided for surgery, so what we all usually face is what dilemma is whether we do a short or long segment fixation, whether we should do a monosegmental versus a short segment fixation, whether we should do a short segment with or without intermediary screw fixation, or whether to do a posterior fixation alone or a anterior column reconstruction. So these are the examples. That's the monosegmental fixation. That's a short segmental fixation with intermediary screws, long segment fixation, Again, a short segment fixation with anterior reconstruction, a long segment fixation with anterior reconstruction. So let's see where we do and what we do. So these are the two classifications which actually guide us ultimately what we want to do. So let's see how these classifications help us in our future slides. So that's a typical monosegmental fixation. And whenever you do a monosegmental fixation, it is kind of mandatory to do a interbody fusion also. So that it becomes more stable fixation. So when can we do such a monosegmental fixation where we are fixing only one disc level? So that is, if there is only one end plate involvement is present, both pedicles are intact of the index vertebra and kyphosis is less than 15 degrees. Yes, we can say we seldomly need surgery in such kind of patients, but these patients, when they present with neurological deficits, so you might have to do surgery, then you can do monosegmental fixation in such patients. So it is of literature which supports that monosegmental fixation is an effective method when it is done in a properly indicated patient. Again, another paper which supports monosegmental fixation if it is done in a properly indicated patients. So what is the advantages? Advantages is definitely it takes a less operative time, less blood loss, less segments fused, especially when it comes to lumbar spine, less chances of adjacent segment degeneration, and especially useful, as I said, in lumbar and thoracolumbar junctional spines. And its disadvantage is it's a less stiff construct. If you don't choose your patients properly, there is a more chance of implant failure. If there was a kyphosis initially and then you have corrected that, there is can have a loss of kyphosis reduction, and there can be need of supplementary bracing or activity restriction. So now when we span two level discs, so that's called as a short segment fixation. There can be we do one vertebra above and one vertebra below. So, or this is a monosegmental fixation. So what is the difference? So you do short segment fixation when both end plates are involved. That's a type A4 of a burst fracture, and significant kyphosis is there more than 15 degrees, and pedicles are involved, and fractures are involving posterior ligamental complex at different levels. So that's an example again of two types of short segment fixation. One is we have used the intermediary screws, one where we have not used intermediary screws. So let's see what is the advantage of these intermediary screws. As we were already discussing, with the advent of intermediary screws, the long segment fixation is almost has become a rarity when it comes to thoracolumbar, especially burst fractures. Until unless it's a type C, it has become a rarity where we do a long segment fixation. So actually it gives the better stability, and it also helps you in reducing the kyphosis in a better way and restores spinal canals by pushing the retropulse fragment when you put this index screw into the pedicle. So these are few articles which support the intermediary screw fixation and which is more superior over just doing a short segment fixation, one vertebra above and one vertebra below. So then next thing is a long segment fixation. Long segment fixation when you involve more than 2 disc levels. So if you involve 3 disc levels or if you involve 4 disc levels, that is 2 vertebra above and 2 vertebra below. So it is indicated in translational injuries, that is type C injuries, or if you have a load sharing classification score of McCormick Gaines classification score of 7 or more. And if you don't want to do an anterior reconstruction in these patients like Junaid did, where the LSC score was more than 7, and he did an anterior reconstruction with a short segment fixation. But then if you want to avoid doing anterior reconstruction, you can do a long segment fixation. And in a non-compliant, a psychotic patient, or where you see that patient is not able to adhere to your post-op bracing, so you can again do a long segment fixation. It's a very stiff and stronger construct. It has got a high failure strength, and there is no significant loss of motion in upper and middle thoracic spine. You can do it there. In lumbar spine, actually, you have to choose your patients very well. and there is no need for bracing and restricted activity when you do long segment fixation. Obviously, when we do a long segment fixation, there is more operating time, more blood loss, more morbidity. So more loss of motion in thoracolumbar junction when we do it at there, because we are going to involve lumbar segments, and increased chances of ASD because it's a more stiffer construct. There are few articles which actually compared short segment versus long segment fixation, and you can see that they inferred that there is no difference between ultimately doing a short segment to a long segment fixation. So then again, one more paper which suggests basically a short segment fixation is almost equal to doing a longer segment fixation. But only they say that if you do a longer segment fixation, the kyphosis correction and maintenance of that kyphosis correction is better than compared to a short segment fixation. So these are biomechanical studies which ultimately say that a longer segment fixation is required if you're not doing a anterior reconstruction. So this is like a mathematics now. When we do and what we do. When it comes to translational injuries, when you want to do a long segment fixation, when you have a LSC score of less than 7, you can do just a posterior alone fixation and get out. If it is 7 or more, you can do posterior plus anterior column reconstruct. If it is no translation, if it is a type B injury, then you can do a short segment fixation with less than 7 score, only posterior. If 7 or more, posterior plus anterior, or you can do a long segment fixation. So in summary, monosegmental fixation can be done only if one plate is involved. Short segment fixation if both end plates are involved with kyphosis. Intermediary screw fixation is preferred in wherever it is possible, and it is the game changer. And long segment fixation with or without anterior reconstruction in type C injuries. Thank you.
Thank you, Dr. Gururaj. That was excellent, very precise and to the point. And now let me invite Professor Anwarul Islam to speak about thoracolumbar fractures in a polytrauma situation, when and what. Over to you, Professor Anwar. Meanwhile, we can keep the questions ready for Dr. Gururaj and Professor Anwar.
Unmute karo.
So you're unmuted, sir.
Okay. Okay, thank you, Dr. Ranjit, for giving me the opportunity to tell something in front of all of you. My topic is on thoracolumbar fracture in polytrauma, when and what. Look at this scenario. Mrs. Nissa, 21 years old, presented to the casualty department of our hospital with the history of fall from height on her back. And she was respiratory distress and pain in the back and upper part of the left thigh as well. Let's get directly to the clinical examination part for discussion. Regarding chest examination, decreased chest movement and diminished breath sound on both lung fields. Hyperresonant percussion note on both lung fields. Left lower limb was found apparently shortened and more externally rotated. Ecchymosis was present over the lateral aspect of the left upper thigh. The tenderness present over lateral aspect of the left upper thigh as well. The sensory diminished along the distribution of the L3, 4, 5 and Ashan dermatomal region bilaterally, and distal vascular status intact in the both lower limbs. Muscle power of the both lower limbs was 2/5. That is knee flexor, extensor, ankle plantar, and dorsiflexors, and inverter or everter of in all. It was ASSI injury. This is the X-ray. You just see the patient presented with the intertrochanteric fracture as well as this is the intertrochanteric fracture, and this is the chest X-ray where you can see the involvement of the both lung fields, and this is the X-ray of the lumbosacral spine where you can see the lumbar fracture at the L2 level. You just see, though it is a not good X-ray. This is the MRI. MRI which can show the L2 fracture and how much the neurological compression over there. And You just see the how much the retropulse fragments over there, and it was more on the left side. This is the CT of this patient. You just see how much the retropulse fragment and fracture was there. How would you manage this case? Which one should be treated first, and when would you treat the thoracolumbar fracture and how? This is the question. It is defined as a clinical state with the following criteria of the multisystemic involvement. That is a definition of the polytrauma, you know all. And polytrauma patients may present with associated thoracolumbar fracture with or without neurological compromisation. But this patient has ASSI injury. While the concept and timing of fracture fixation for isolated spinal injury with or without neurological compromisation are well defined in the pertinent literature. The question about the ideal time point and modality of spinal fracture fixation in severely injured patient remains an ongoing topic of debates. This is damage control orthopedics. Damage control concept for the unstable spine injuries have not been widely implemented yet. There is on literature where spine damage control is a safe and effective treatment modalities for the unstable thoracolumbar fracture in a polytrauma patient. It was a hypothesis. Unfortunately, both concept conservative caution and aggressive primary fixation bear inherent risk and danger for severely injured patient. So, in a damage control surgery, there are some potential benefits. That is definitive surgery in a more stable patient, convenience for surgeons and operative schedule. Potential complication are increased antigenic load, that is increased stress and pain, prolonged bed rest, which may lead to the pressure sore, DVT, and pulmonary complications. Difficulty in adequate positioning or mobilization. You just see early total care. The patient needs early total care for such type of patients. Potential benefits are early stability of the spinal column, reduce antigenic load, and unrestricted mobilization and positioning option. No secondary neurological deterioration. Potential complications are hyperinflammation, increased blood loss, and inadequate resuscitation, aggravation of the lethal triads of death, which may lead to SRIS, sepsis, or MSOF. So, what do we do? What we should to do? As we all know, the management of polytrauma patients should proceed according to the ATLS guideline, which consists of the primary surveillance, simultaneous resuscitation, a rapid assessment and treatment of life-threatening injuries, and then secondary survey and detailed head-to-toe evaluation to identify all the other injuries, and definitive care, specialist treatment of identified injury. In a polytrauma patient, the consequences of steps for treating different types of injuries is vital, and the window of time during which surgery can be performed for bone injuries is often short. At first, we have to ensure that the patient's ABCs are stable. We should then undertake a detailed secondary survey to identify any other injuries which may have been missed in primary survey. Reasonable precautions should be taken to prevent any other injuries or deterioration of the patient during this period. For example, examination must be done in neutral position, mobilization by locked roll method, transport and neutral position in spinal board, and use of cervical collar alloys. Suspected TL injury during primary survey of the patient excludes spinal shock and treat immediately. Imaging for suspected thoracolumbar injuries should be rational and timely. Finally, in tertiary survey, categorize the patient according to the various available classification system for developing a proper management plan. You know, thoracolumbar injury classification and its severity score on the basis of the fracture mechanism, neurological involvement, and posterior ligamentous complex integrity. You know all. I will not go details. This is AO classification of thoracolumbar injuries. You know all. McAfee classification, Dennis classification, and other classification as well. Treatment timing and modality of the thoracolumbar injuries in polytrauma patient may also be affected by the presence of associated limb or pelvic fracture. This is on literature, early versus delayed stabilization of femoral fracture. There is a wide consensus on the notion that femur shaft fracture should be stabilized as early as possible in polytrauma patients in order to avoid potentially lethal complications. Where a patient with thoraco-lumbar fracture can be treated conservatively or needs surgical intervention depends on several factors like fracture mechanism and type, neurological involvement, PLC integrity, amount of loss of vertebral body height, and degree of kyphosis, etc. Operative, different methods of operation: posterior decompression and stabilization, anterior decompression, stabilization, percutaneous fixation and decompression, that is MIS, long segment, short segment, various debate. Let's get back to the case we discussed earlier. The patient was at first managed in the casualty department of our hospital by the hemodynamically stable. It was made by the anesthesiologist, respiratory medicine specialist, and the medicine specialist as well, and by the orthopedic surgeon. At first, we put the upper tibial skeletal traction for the trochanteric fracture. And after achieving many stability, she was shifted to the operative department where the underwent ORA by DISS on the left side, done by trauma team. After a week, she was treated by posterior decompression with posterior short segment stabilization by pedicle screw and rod, including apex vertebra from L1 to L3 for burst fracture of L2 vertebra, done by our spine team. That was the fracture. And that was the surgical procedure from the posterior sides. We putting the short segment fixation with putting index screw. And you just see the postoperative X-ray of the fracture management of the TL fracture as well as the trochanteric fracture. The effect of polytrauma in person with traumatic spine injury, that was by Jackie S. Harvard. And in case of polytrauma, complex bone surgery in a prone patient may prove to be quite delicate in the immediate hours or delays or days following the trauma, which often leads to a poor prognosis in the short and long term. This is another paper, that is cold traumatic lesion of the dorsal and lumbar spine. On the other hand, if the fracture are treated 3 to 4 weeks after the trauma, this makes it difficult to be obtain satisfactory reduction of the sagittal plane deformities and increases the risk of the union in kyphosis. That is percutaneous kyphoplasty or pedicle screw fixation for the management of the thoraco-lumbar burst fractures. The presence of associated lesions could make it difficult to perform conventional spinal surgery early on. Recent development of percutaneous techniques that reduces perioperative morbidity seems to be an alternative approach suited to damage control orthopedics and could improve the initial care of this vulnerable case. This is another paper. The combination of quick fixation of spine injuries and the minimally invasive techniques seems to be particularly relevant in severe polytrauma patients who have a very short surgical window. Treatment sequence for this patient should be standardized and determining according to the degree of urgency of the initial lesion. Recognition of the individual fracture pattern and neurologic compromise, as well as reasonably management and timing considering the associated injuries, is mandatory for a satisfying outcome. Thank you everybody for patient sharing.
Thank you, Dr. Anwar. May I call upon Dr. Ranjit for his talk now?
Yeah, Dr. Gururaj, can you allow me to share the screen?
You can share. Yeah.
Okay, you're seeing my screen?
Yeah.
Okay, thank you very much, ASSI and BSS. Glad to be with my friend from Bangladesh Spine Society. So with the current discussions, let us set the ball rolling. What is the role of minimally invasive surgery in thoraco-lumbar fractures? So we have been discussed today many times. What are the factors which we decide in when you treat these fractures? We know we look at the AO or the TLIS classification. We look at the neurologic injury. We look at the fracture pattern. We also look at the patient factors like is it an Angstrom spine or a dish spine, like a stiff spine. And we also look at, as Professor Anwar just mentioned, is it a polytrauma situation or is it a isolated spinal injuries? We also dealt that we look at the PLC and decide if it's stable or unstable, and we want to operate them for the progressive deformity or for the pain. Now, we have Dr. Gururaj very clearly enlisted these goals when you treat these fractures. It is realignment, it is decompression, could be direct or indirect. It could be stabilization with the way of instrumentation. And do we need fusions? Rarely we need fusions. So can we achieve all this, via any method? So the first three things is which can easily be achieved by using MIS technique. And do we see that, do we need fusion in these fractures? So the questions which comes to one's mind is that if I decompress, how do I decompress? If I have to fuse, how do I fuse? And if I have to reconstruct the anterior column, how do I do it in MIS way? And if I do MIS, do I end up doing longer fusions with MIS? With this, a lot again, well upon this has been discussed today, time and again. This is the unstable fracture morphology, wherein we go in for surgery. And we also look at these neurologic status based on which we decide about surgery, and polytrauma and obesity. So this, in my part of the world, obesity has got a very important decision-making factor when it comes to management of these patients, because managing a obese patient non-surgically is quite a headache for us, with the risk of DVT and pulmonary embolisms. So again, we look at this picture. Now, decompression. We heard this discussion some time back when Dr. Shah Alam mentioned the surgical clearance of the canal does not affect the neurological outcome. Published way back in 2000 by Professor Dixon. Then, what are the indications of canal decompression? When there's, what are the indications when you can do an indirect canal decompression? Moderate canal compromise, when the patient comes in fresh within first 40 to 70 hours, with intact PLL, and we don't do it when we see a reverse cortical sign on the CT, also when there's more than 70% canal compromise. These are situations where we should not go for a indirect canal decompression. We have to go for a direct canal decompression. Now, this is one of our patients where we went ahead, and this was the burst fracture with the ASSI neurology, ASSI. We went ahead and she had incomplete deficit, more than 50% canal compromise. So there was no reverse cortical sign. We went ahead and did those days, this is almost 16 years ago, went ahead, did a 2 above, 2 below, did not touch the canal, and look at how beautifully the canal has remodeled over 18 months. This is our own patient. So we know that we don't have to always decompose the canal. What about the anterior column? This has been proved beyond doubt in 2020 that the short segment pedicle instrumentation can be sufficient and safe enough in treating thoraco-lumbar burst fractures, and load sharing classification is losing his strength as a predictive value regarding sagittal regarding anterior collapse. So the so-called LSE is really questionable. And again, there's another paper which even Dr. Gururaj quoted some time back, that more than LSE 7, we can go in for a short segment fixation, don't have to do a long segment, or do not do an anterior canal reconstruction. Now, how is all this possible? Because of this beautiful thing called index screw, which will prove beyond doubt that it increases stability by 31%. There is less post-op kyphosis, less incidence of implant failures, and helps to reduce the level of fixation from 4 to 3. Again, the index screw, multiple paper saying that it helps in better maintenance of kyphosis and the kyphotic angle, thus avoiding anterior surgery or even anterior column reconstruction. Now the question about fusion. This is one thing which is very questionable when you come to type A3, A4, or a B1, B2. In type C, we know it's a fracture dislocation which needs a fusion. So no question of MIS in those, even though I know it's been published by Ganga Group that you can do in them also very safely. Now, fusion in B2, B3, stiff spines needs fusion. So we are not discussing it. The vast majority of burst fractures, it's been proved beyond doubt that fusion will not improve the deformity and functional outcome, but it adds to bleeding, donor side mobility, and time of surgery. So this paper in 2017, is fusion necessary for thoraco-lumbar burst fractures? It was a meta-analysis which came out with the outcome that use of fusion did not improve clinical outcomes, but it was associated with increased surgical time and higher intraoperative bleeding. So there was good enough reason not to fuse any of our burst fractures, which amounts of fact that we can treat them minimally invasively from posterior approach. Now the question, if I have to do an anterior approach, an anterior column reconstruction in these patients, can I do it MIS? Yes, this is one of our, I'll not go to the want of time. These are one of our cases where we did, beautifully, we can reconstruct the anterior column by the index screw. I typically always use, whenever possible, 2 index screws on both the pedicles, irrespective of the pedicle fracture, and we can beautifully restore the focal kyphosis by MIS techniques. Now, in case I need a corpectomy, can I do it MIS? Yes, very much. One of our patients where we went ahead and first did a posterior column reconstruction, followed by, this was an 83-year-old lady, where we went ahead and did first posterior, then we went ahead and did want of time, I'll skip those slides. We did a minimally invasive, anterior thoracic corpectomy and used a cage. So it's very much possible to do anterior and posterior via MIS approach. Now, a note on osteoporotic component fractures, even though which is not the direct topic of this seminar, in these cases, we should distinctly differentiate between intervertebral instability versus intravertebral instability. We know the whole lot of procedures wherein we have vertebroplasty, kyphoplasty, balloon kyphoplasty. Now we have the vertebral body stent, wherein you do what? In a case of intravertebral instability, these are classical patients wherein you do a stand-alone vertebroplasty, this is going to fail. So look at these patients, we typically get these shoot through lateral supine x-rays, where you can see in this patient with a D12 burst that it just opens up like a balloon, once you do a proper supine shoot through lateral. So this to start with was this injury, which eventually over time went ahead and developed these. So these patients, when you see this cleft sign on day 1 or day 2 or 3 weeks, these are the ones which are going to progress, are going to develop a kyphosis, going to develop pain. These are patients, you should not sit on conserving them. Irrespective of your medical management with teriparatide and calcium, whatever, we go ahead and we did these. This was done way back in 2010, 2011, wherein we did not have the Indian systems. We used this sextant by the Medtronic company, and we did cement and screws. So to Dr. Shah Alam's question about doing long sequencer, this I've got a 14-year follow-up on this patient today that she's still holding same. We did a short column fixation with a transpedicular cement and she's holding on. So again, to ask, is minimally invasive surgery treatment of thoracolumbar trauma and lumbar trauma safe? So this paper came with the outcome that minimally invasive surgery in the spine holds significant promise, but the current body of evidence is mediocre at the best and leaves many questions yet unanswered. If you look at it, this is published in 2014. We are 10 years down the lane, and what does literature tells today that the use of minimally invasive surgery in trauma, this paper was published in 2021, which went and said that MIS techniques have the potential to reduce open approach associated mobility and improve post-operative care and rehabilitation. MIS techniques for spine trauma are an indispensable option. Mind the word indispensable option in the treatment armamentarium of spine surgeons. We heard Professor Anwar right now quote literature which said that it's very important to have MIS techniques, especially in polytrauma situations. Again, comparison of percutaneous MIS techniques versus open spine, open fixation in thoracolumbar fractures. It was a retrospective cohort analysis by Stephen Ludwig from Baltimore, which looked at 100 patients of MIS and 155 patients of open, which was a retrospective analysis study, which said that MIS for treatment of thoracolumbar fractures are very beneficial. It has got decreased operative time, decreased blood loss, and fewer transfusions. Very important in a polytrauma situations. So what are the pros of MIS techniques? Number 1, decreased blood loss. It hardly needs any post-op transfusions. It's quick. You don't spend the time opening up, closing, suturing, putting all that. There is decreased operative time, less post-operative pain, less incidence of surgical site infections, And in isolated fractures, minimal hospital stay and less chance of proximal junctional failures or proximal lumbar failures, and because we preserve the midline. So to take home, I conclude saying that all thoracolumbar fractures are not indications for MIS surgery. Don't do it in a type C fracture or in one which requires posterior fusion. Remember, the surgical goals of open as well as MIS are the same. Just because you're doing an MIS surgery, you should not do a minimal surgery or end up doing a minimal decompression. You have to restore, the goals are the same. You have to aim and strive to achieve it the same way you do open. In case of osteoporotic fractures, assess for intra or intervertebral instability and use these procedures, vertebroplasty, kyphoplasty, with care. And when in doubt, you can go in for hybrid techniques. Thank you very much. Any questions?
Thank you, Dr. Ranjit. The session is open for discussion for the talks of Dr. Anwarul, Dr. Ranjit, and myself. Yes, if anybody has any questions.
Yes, Chabbra, sir.
Yeah, Guru Raj, you had mentioned that in the thoracic and thoraco-lumbar spine motion segments, the number of motion segments you fix do not make any difference in the outcome.
No, sir. I said motion segment, they make the difference. So that is why I said we need to fix lesser segments when it comes to thoracolumbar and lumbar spine.
No, but thoracic?
So thoracic, I know basically, I would say the thoracic is the lesser evil as compared to the lumbar and the thoracolumbar junction. But then the thoracic spine also is very important because in a wheelchair-bound patient, the rotatory movement is very important.
That's what I wanted to point out. You made a difference. You said thoracic, it doesn't matter as much, and thoracolumbar and lumbar. I would only want to contest that. I think all levels it's important to say motion segments, especially in those with neurological deficit, because their independence on the wheelchair depends on the rotational movement, which is there at the facet joints, which gets compromised with the level of fixation that you do.
Thank you, sir. Any other questions? If no questions, then I would like to move to the next case. That is from Dr. Ashan, Dr. Kamrul Ashan.
Thank you, Guru.
Yes, sir.
Is it visible?
Yes, sir, it's visible.
Yes, sir, you can go ahead, sir. Let's see.
Okay, thank you, Guru.
Sir, continue. Kamrul sir, continue.
Yes. Yes, case presentation. 45 years old male, day labor, had a history of fall from top of the running bus and sustained trauma on his back, chest, and abdomen. And he is diagnosed as a case of polytrauma victim. Initially, he was managed according to ATLS protocol at district hospital by chest drain, nasogastric tube, and 2 units of blood transfusion. 2 days later, he was transferred to private hospital, ICU, and managed accordingly. 2 weeks later, he came to our emergency unit, and examination we found patient was conscious, GCS score 15, patient is anemic, blood pressure 90/50, pulse 90 beat per minute, respiratory rate 22 per minute, and there is a gross deformity present on his back. And patient is unable to move his both lower limbs, and catheter in situ. And hematological investigations found hemoglobin 9 gram per liter, neutrophilic leukocytosis, creatinine 1.7, urea 56, ESR 45, C-reactive protein 12 milligram per liter, serum amylase, serum blood sugar, serum electrolytes within normal range. XSS shows there is a haziness of the right lower zone, and ECG was normal. And neurologically, we found sensory absent below D12 and motor power both values 0, bulbocommons reflex present, but no sacral sparing, no voluntary anal contraction, absence of any sensory at C4 and C5 level, and absence of deep anal sensation. So according to a shear impairment scale, it was a case of type A, that is complete spinal injury. And this is an X-ray, plain X-ray and lateral view. I missed the AP view. Here shows and a complete translation at the level of D11 and D2 over the D12, and cervical spine X-ray and others normal. I want to put a questions. Will you go for CT scan or MRI? Which one you would prefer, faculty?
Okay, Dr. Ajay? Sir, you're muted. Okay.
Anybody?
So I would do a CT scan rather than MRI because I already know that what is happening to the cord there. So I would do a CT scan to see the basically pedicles and how much of body is anterior to the lower body. So, but then typically we would both. But then if given a choice one, then I would do a CT scan.
If it's a polytraumatized patient, I think it's better to get a whole body CT so that if it's available.
Yeah.
Quick screening.
But patient is come to be for family. Unfortunately, we don't do any CT scan. We did only MRI.
Sir, can I ask one question?
Yes.
Sir, is there any X-ray of the other limbs and long bones as well?
Yes, there is one X-ray on the right forearm. There is found fractures in the styloid process on the right side. And other limbs injuries, okay. And cervical spine, there is no cervical spine injury. Only there is this type of injury. So we did not do any CT scan, only MRI.
Sir, in a thoracic injury, whether it was the spontaneous pneumothorax or other form of thoracic
yes,
injury,
the patients initially treated in ICU, there is a hemothorax and potence has drained and treated in ICU for at least 2 weeks. After 2 weeks, patient come to us.
So that's a very
important 2 weeks, the patient was hemodynamically stable, sir.
Yes, I also already mentioned the hematological investigations.
Yes. So that's very important point. Whenever it comes to type C injuries at thoracolumbar junction and thoracic spine, you should always go ahead and do a chest CT to see a pneumothorax and chest injuries.
Yes, patients suffering from hemothorax and they are treated in ICU. But after come, we found plain X-ray. Plain X-ray only there is a haziness, nothing else. And patient disease score is 15 and patient is almost stable.
Okay.
And this is an MRI.
So initially there is a fracture dislocation, that is type C injury of the D11-12 with the spontaneous pneumothorax. No head injury or other thing was.
No other injury. Patient disease score was only 15.
Okay, sir. Okay.
Okay.
Okay, so what to do? And this is a case of complete paraplegia due to traumatic spondyloptosis at D11 over D12.
I think Dr. Sahil has been very quiet all the while. Dr. Sahil, what do you want to do? Such a patient, 2 weeks old, with a kind of situation.
So 2 weeks old, I think, as this is a type C fracture dislocation, there is a complete deficit and the patient is now stable. So the surgery is the only choice, and long segment fixation would be the choice of fixation in this. As we do not have CT, so we do not know about the pedicles of D11 and D12. And we also don't know about how much the combination is in the lower body, that is the D12. But the major problem in such cases, if it is 2 weeks old, is the how do we reduce such fractures? And
Yes.
there are many reduction maneuvers which have been described, but when they in complete spondyloptosis, I think we'll have to do a wide laminectomy, 2 or 3 levels, and a complete facet resection. I'm not sure. I've read articles about pre-operative halo pelvic traction or halo bifemoral traction, but I don't know. I have never personally used it or seen it. That I would like to ask the faculty over here if anybody in such 2-week-old fractures, whether they put a patient on a pre-operative traction or just go in the OT and then put in reduction screws, do all the maneuvers with the rods and do a complete facetectomy with laminectomy and try to reduce such fractures.
Dr. Junaid?
Ajay sir has a point.
Yeah. Sir, I will come to you, sir. We'll come to you. Junaid?
Yeah.
How will you reduce this fracture? This
So,
location?
basically, this is a case of already 12 days old. As
12
one thing is
weeks.
that
2 weeks old. 2 weeks old.
yes, that means 2 weeks. So good things is that as it is a complete spinal injury, so no worries about the neurological status. So in that particular case, we usually do, after the midline exposure, first of all, we need to dissect the facet and put the longitudinal traction and levering of the lower vertebra, and just put a pressure on the forwards and backwards and upwards, so that the proximal vertebra, it is rotated upwards, so it can be easily reduced. Is it clear?
Okay. So let's hear Dr. Ajay. Sir.
No, I agree with him. Like 2 weeks should not be a problem of reduction.
Yes.
It's relatively mobile. There are many different techniques. You can put a rod proximally, rod distally, hold it, lever it, remove the facet, distract it, and try to reduce it. There are many ways to do it, but 2 weeks is not a problem. If it is 2 months, then without corpectomy, you won't be able to reduce it.
Yes.
And can I, Dr.
Yeah, Ranjit.
So in these patients, more than the reduction technique, be careful about the soft tissue injury, what will happen when you try to reduce it. So if I have faced 3 months, 6 weeks, 8 weeks, so especially the thoracic spine, the moment you go in and try to do all this maneuvering, you will tear an intercostal and they will bleed. So be prepared about that. The soft tissue, especially the vasculature, there'll be a lot of hematoma there, which works like a tamponade. The moment you try go in, open up, expect a bleed, expect a massive bleed, be prepared for it, or just don't think that we can go for the back and it'll reduce it. So that is the thing to remember. Getting them reduction is not at all an issue. You will get it at any point of time, but the soft tissue, the bleeding is what we should always keep in mind.
Ajoy sir.
Yeah.
Can I ask you one thing?
Yes.
In a 2 weeks fracture dislocation, that is such type of type C injury, not always been reduced easily. Sometimes it is difficult to be reduced. In that situation, corpectomy can be an option, if not reduce usual procedures.
Yes, corpectomy is an option, but most of the time it may not be necessary.
Okay.
As I would like to add, like as Ranjit said,
Ajay, in our perspective, 2 weeks, 3 weeks, even we have to do surgery. And it is true that after mobilizing, even the manual traction, sometimes we do it. There are a lot of ways to reduce, but also we give the traction holding the head portion, also the lower portion. And since it is a complete the transected, nothing to lose. So it is possible. 2 weeks is okay, but it is true. There is a 4 weeks or 6 weeks or 2 months even. Then it is very difficult and sometimes.
Yes.
And facetectomy, not that much, because already facet is dislocated.
Disrupted.
Facet already disrupted. Facet already disrupted.
Okay.
Ajay sir, what point you want to add?
I agree with you. This is not a case which should send our junior most resident to do, because suddenly there will be a blood loss when they try to manipulate. It may be 500 ml, 1 liter of blood loss.
Yes,
and
sir.
That's what is important.
It is important. And
not only during manipulation, even sometimes it goes most in front can damage also the blood vessel.
Blood vessels. Anteriorly.
That is it. The very vessel damage.
Yeah.
So it's routine for us, after we have these old injuries, we immediately get a chest X-ray done, and slightest doubt, put a chest tube inside. Put a chest tube inside, and then we take the patient out of the theater. Just get a chest X-ray done, because the bleeding might not be happening into the wound. It might happen into the thoracic cavity. And then
Right.
you don't be able to extubate them. So we always get a chest X-ray done and put a chest tube. Slightest doubt, put a chest tube.
This is the
So,
right
Dr.
issue.
Ranjit,
Good
is it your routine practice?
These old presentations, fracture dislocate, because like Professor Shah Alam mentioned, I've had great vessel injuries. After 2 months, T6, T7, T4, T5, root of arch of aorta. Old ones did all the heroics, reduced it. Post-op patients, hypotension. The thing was that the vessel, I lost the patient because it was, in old injuries, you try to earlier days in career, you did not understand that the soft tissue is contracted there, it is fibrous there, you are trying to go do all the heroics, you are just focusing on the vertebral column, and then you end up disrupting the vessels. So be very careful with these. Like what sir mentioned, only the most experienced should go in for this case. Because you think it is type C, there is nothing called spinal cord there. Don't just go in and try to do this thing. You will
Ranjit.
Yes, sir.
Ranjit, not only for the thoracic spine, can be in a lumbar and cervical spine as well.
True that.
Yes.
More common in the thoracic spine and thoraco-lumbar junction.
Chabbra sir.
I am very much agreed with Ajoy Shetty, as he mentioned that since there was sometimes we think that okay, total transaction just install juniors go and do straight away. It is not that, because there is no chance to regain the neurology. But sometimes this sort of catastrophe can occur during a mobilization. It's true. This should be done those who are experienced.
Okay. Yes, sir, I was one of those juniors someday in life, sir. I faced it. That's how I do that.
Yeah. Okay, Ranjit. Sir, Chabbra sir, do we need to reduce these fractures always, or can we do in situ fixations in them?
Yes.
We can do in situ fixations, Guru Raj, but just in case we find a cure tomorrow, right? If we can maintain a patent canal, it's always better, because we can do that easier right now than at a later stage.
Huge give bus. There is a huge give bus.
This is the scenario.
Scenario.
And
it needs to reduce.
But I would only want to mention that it's not always easy to reduce such fractures, because there is a very significant amount of force which results in a spondyloptosis in the spine. Imagine the amount of force that would have done this, and you have to recreate that force to correct it. So in such cases, sometimes we have used the Harrington distractor as very useful in trying to reduce it. And I would not hesitate in doing a shortening procedure by doing a corpectomy, because then reduction becomes very easy for me, and trying to maintain that vertebra is not serving any benefit to me. So I would, rather than doing a lot of struggle and trying to also cause vascular compromise, as mentioned before, my threshold to do a corpectomy and reduce it would be low.
Okay, Dr. Kamrul, Ashan.
Okay, thank you.
I do agree with Dr. Chabbra sir.
What we did, we did posteriorly, everything go for posteriorly. And what I find, after giving an anesthesia, I start incision from above and below, and then go the flexor side. After releasing all the muscle from the both proximally and distally, there is some sort of reduction is automatically occur. And then I put in screw, 4 screw above and 4 screw below. Then I put a long rod, then distally, and by giving a towel clip distraction, it is automatically reduced. And then I put in another rod. And this is the patient scenario.
Nice.
And this is the follow-up X-ray. Okay,
Nice.
but unfortunately, after 3-4 weeks, patients develop severe pneumonic consolidation and respiratory distress, and patients again shifted to ICU, and ultimately patients develop septicemia, and he expired after within weeks.
Okay, so
one thing is that after exposure, I found there is a CSF, huge CSF leakage, and dura is totally lacerated. So what in this situation, what will you do? And dura is totally lacerated, and there is a CSF leakage continuously.
So usually, what in my experience, what I've seen is traumatic dural ruptures or complete transactions.
Completely transaction.
The CSF leakage stops after some time.
Yes.
So you need not do anything for to stop this leakage, which is even impossible also. So I have not experienced a persistent leakage coming from these sort of injuries. So anybody has any experience, they can comment actually.
I have one question to Dr. Chabbra sir. Sir, in that cases, 7 days after surgery, the patient died with septicemia. What was the reason for septicemic development of the septicemia or further pneumonic consolidation?
You see, the patient was a polytrauma patient and had probably infection even before. So one has to be more aggressive in management and stabilization of these patients. And the surgery would also have been prolonged because you needed to reduce the patient. Plus, the CSF leak also adds to the chances of the infection spreading through the dura as well. So, it is possible. One has to be just more aggressive in such patients in trying to reduce the chance of
infection. What I did, I totally give a stitch in the proximal dural tear. Totally given stitch. So there is a minimization of the dural CSF leakage in postoperatively, and
you ligated the
beautifully healed.
Yes, ligate.
Yes, ligate. And postoperatively wound is completely healed. There is no but subsequently patient developed pneumonic consolidation.
Okay, Dr. Ashan, that's a nice case, and I think you executed it very nicely. But unfortunately, patients succumb to comorbidities. So thanks for your case presentation. We are already 10:17 now, so we'll go to the last case. That is from.
Thank you, Guru. Give me an opportunity.
Yeah, Dr. Sahil Batra is a senior consultant spine surgeon at Jalandhar, and he's been the alumni of ISIC also. So, what to you, Dr. Sahil?
Thank you so much, moderators, for giving me the opportunity to present. I'm not able to share.
No. You are on Apple?
Yeah, I'm on Apple.
Ranjit, please.
No, you should be just able to share screen.
I'm trying to share the screen. It says choose what to share with the app.zoom.us, and I'm choosing the entire screen.
Okay.
But then there are two options: cancel and share. The cancel one is blue, but I cannot press on the share button.
So you hold shift and then you select. Hold shift, and then try to share.
I'm still not able to
hold shift.
Hold
Once you select shift, then show. Are you on an external screen, external monitor, or just your laptop?
Just the laptop.
Yes. Then you should be able to. So once you say shift, share screen, you will see your desktop up there, which says basic, advanced, and files. So go to basic and share your desktop one.
I've just shared on the WhatsApp what I am getting. Dr. Ranjit, can you please see?
I'll just see. Meanwhile, Dr. Guru, you can take questions.
Yeah.
Okay. So I got you. So you're trying to. So you select the entire screen.
touch on the entire screen, but I'm not able to. If you can see.
Then log off and log in. Log off and log in. Don't waste time. Maybe we'll take questions. Log off and log in.
Okay. Yeah.
Yeah. So by the time Dr. Sahil Bhatta is coming in, I have a question to the panelists, to the experts. So in case of a polytrauma, which what Professor Anwar just discussed, what is the pattern you follow, Dr. Ajoy Shetty, Dr. Chabbra sir, in your institute when you have a spine trauma, a spine fracture with a limb fracture with respect to a long bone fracture, not necessarily not a pertrochanteric, what he discussed right now, a femur, a tibia, or a humerus, what gets the preponderance? So we all understand that we have to operate on the unstable spines of a stable patient. So we get the ATLS protocol and procedure. We have the A, B, C, or D all stabilized. Then what do you do first? Do you do the spine first and then do the limb, or you do the limb first then do the spine? If you do the spine first, do you do the limb at the same sitting? And if you don't do the same sitting, do you use an external fixator or anything to temporarily span this fracture while you fix?
You give all the answers.
No, so how do you make out the sequence, sir?
Sir, Dr. Chabbra.
So life-threatening trauma needs to be managed first. That is the principle of damage control orthopedics. So if there is, it may not only be a limb fracture, it could be a splenic injury, it could be any other injury, and that needs to be managed at the first go. If it is a limb fracture like a shaft femur fracture, right, then that takes priority, but a tibial fracture doesn't take priority over spinal stabilization. But even in the spine, you can do just a percutaneous fixation and stabilize the spine and go in for a definitive procedure later when the patient stabilizes. So you have to take each individual patient on his or her merit, and then decide, again, as I mentioned, life-threatening injuries take a certain, a definite priority. It would also depend on whether it's an incomplete injury or a complete injury. And so there are very many factors which were also very appropriately pointed out in the talk.
Number one,
sir, what is your...
unstable patient, stabilize the patient. If it's you have life-threatening injuries, it needs to be addressed. If there is a femur fracture, you put an external fixator. If there is upper limb injury, they do not get any preference till the patient is stabilized. And when the patient is general condition is stabilized, then you fix the spine, do the definitive fixation of the femur whenever the anesthetist or the intensivist feel the patient.
Shetty sir, can I tell something regarding this?
Dr. Anwar.
Hello. I think he's back.
Anwar, he's come back. Let's go with the case. We are already getting delayed.
Okay.
Sorry.
You, Dr. Batra.
Sorry. Yeah.
Cancel the update. Don't do the update now. Don't do the update.
Yeah, no, I will not do that.
So the issue is because you're not updating your Mac OS. You can make.
Okay.
Okay. We can see it. Let's go ahead.
Go ahead.
And am I audible?
Yes.
Thank you so much, everybody, for patiently waiting for this hiccup. So I am also going to present the type C fracture. So I do not have the X-rays with me. And this is a patient who came to, if you can see the date, 29th March 2020, that is the peak COVID time. The patient didn't have an X-ray, but had the CT and MRI and came to me 48 hours down the line. And he came from Himachal and he couldn't travel anywhere. So somebody contacted me that could you operate? And the guidelines in that time for operating were not very clear. But then again, as he was somebody who came with a strong reference, so I had to operate. And X-rays in our hospital, in the hospital where this patient got admitted, the X-rays on those 2 days were not available.
No, it doesn't matter. You have a CT, it gives more information.
So it's the CT is there, and this is a type C dislocation, and there is a fractured body, and so you've seen complete spondyloptosis in the previous case. This is almost like a grade 2 listhesis or a dislocation. So patient was a 34-year-old male, fall from height, came to me 48 hours after the injury. There were no comorbidities. There were no other injuries. The patient was stable hemodynamically. The patient had terrible amount of pain that he could not even turn in his bed. So shifting him was a problem anywhere. So now this is the MRI. So what is the mode of the treatment? I think everybody would agree that a surgical treatment is required. Patient is Asia A with a neurological level of T12 with complete bladder bowel injury, complete absence of perianal sensations and voluntary anal contraction, and there is no movement in lower limbs, no other injuries. So what next? What are the things to decide? One is the timing of surgery. As the patient came to us 48 hours late and he was hemodynamically stable. So I think timing of surgery was the best whenever we could get the whole team available. In such type C injuries, would the neurological status change anything in the treatment? Dr. Guru?
No, it's ultimately it's an unstable type C injury. So we need to ultimately operate and stabilize this. So
would any of the reduction maneuvers change if it is an Asia C versus an Asia A?
So if it is a incomplete injury, then definitely I would drive hard to achieve a complete reduction. If it is a ASA, then I would accept whatever reduction I get. I would like to get that kyphosis corrected at that level and get a good alignment.
And like in the previous case we discussed, there are a lot of reduction maneuvers which Dr. Ajoy also pointed out. There are different reduction maneuvers described by AO, by fixing rods either distally and then trying to put lamina spreaders or a facet spreaders or putting a corbs inside or doing facetectomies. So whatever way we achieve in reduction, but do this pulling the spinous processes via towel clips or the lamina spreaders, would you use such kind of maneuvers in Asia C injuries and incomplete spinal cord injuries? Or would you like to do a laminectomy and a facetectomy and shorten the spine to reduce it better so as to avoid any further neurological deficit?
Sir, Dr. Ajay?
See, my reduction maneuver remains the same. The only thing nowadays what I would do is I would probably use a neuromonitoring, but my reduction maneuvers will remain the same. But what I usually do when a patient is neurologically intact is stabilize it, put the rod distally, use reduction devices or reduction screws, gradually try to pull it up, at the same time gently distract to disengage. Basically, you need to disengage because when it translates anteriorly, there is always an impaction. You need to disengage a bit and then the reduction happens gradually. Shortening is much more damaging procedure, especially in a patient who has got an incomplete injury. Doing a whole vertebra removal is not a simple job.
So in particularly in that case, in a grade 2 listhesis, is there any need to be shortening of the column?
No, not necessary.
Not necessary at all.
Usually in a situation like this, the facet locking would have happened.
Yes.
Just need to exercise the facet to achieve the reduction.
So facetectomy bilaterally, then distraction over the spaces, remove the disc and other things. And if you use the reduction screw, I think it will be easily reduced.
So how many would do an interbody fusion here?
Yes, I would like to do interbody fusion if it is Asia C. But in Asia A, in situ fixation and fusion, I'm not going for the reduction or reduction even as well.
Okay. Anybody who will not do interbody fusion or who will do interbody fusion? Any comments?
I have done interbody fusion, but nowadays I have given up because it doesn't make any major difference. Apart from adding to a lot of blood loss during the procedure, because already there is disrupted vessels. I mean, I had done in patients hoping that it might improve a neurological deficit, especially patients who present less than 12 hours. but never found any difference apart from taking more surgical time.
I agree
Same,
with that, sir.
same,
Stabilization is okay.
same here. We used to do interbody fusion before, but now it's given up. Okay, Dr. Syed, go ahead.
Incomplete neurological status, then there may be need for the interbody fusion. In that cases, I think.
Unfortunately, in a spinal fracture, there is nothing that has proved to be effective apart from we have to reduce, align. Know the technique, whether it's posterior, anterior, you do which you are comfortable with.
Surgical technique. What matters is ABC.
Yeah.
Yeah.
And what is the does anybody use an intradiscal maneuvers to reduce such fractures? Because sometimes the facets are completely disrupted, and if sometimes there is too much of spinous process damage and we cannot pull it by towel clips. So do you use putting a cobs inside the disc and try to maneuver it, or does it cause?
It all depends whether it's Asia A or whether it's normal neurology or
ASSI. That depends on the neurology.
Yes, if it is Asia A, you always much more do whatever you want to do.
Yes.
And not causing more blood loss. You don't want to lose a patient because of blood loss. But apart from that, you are more aggressive.
Yeah. So, and Dr. Ranjit, my question to you is that in fresh injuries, have you seen such in complete dislocations, vascular injuries happening in fresh traumas? You talked about the older times if the patient comes to you after 4 to 6 weeks.
So
then
fresh traumas we have seen happen because we practice in a place where there's a lot of high velocity injuries, but they're always diagnosed because we have a protocol of whole body CT before we proceed. So of course they are there and they are primarily managed.
Okay.
Sir, Chabbra, sir?
Yeah, I only tend to differ in that in incomplete injuries, I would definitely want to do intradiscal work in order to attempt good reduction, in order to do a decompression procedure. So if this is an old injury, there would be some amount of fibrosis both behind and in front. And by doing a discectomy, the chances of reduction improve. So I would go in and do a discectomy, try to achieve a reduction. I would definitely achieve a reduction in this case if it is an incomplete injury. And if I do a discectomy, then I have to do an interbody fusion.
Okay, last comment from Ranjit, and then Sahil, you can proceed.
So in these cases, a lot of the maneuvers what you use depends upon the neurology status. In incomplete neurology or a partial neurology, you should end up, like sir mentioned, try to shorten the column. Don't try to manipulate much. If it is complete neurology, it's in Asia A, you can do anything. So whatever maneuver you require, and time and again, I think sir has been emphasizing that whatever you do, keep in mind that you have to have an aligned spine and a clear canal. You don't know the future. That's what the message I get.
Okay.
Then going ahead, this was the intraoperative picture before when we exposed. So it wasn't much reduced just after the exposure. And this was the intraoperative image when we made the patient prone and after exposure, what we took. And this is what I did. And this was the minimal bony work we did. And just decompressed. This is now the spine was completely decompressed and aligned and reduced. And if you see, this is the immediate post-op X-ray. I did a long segment fixation and I used an index screw in the fracture site. And it was completely aligned back to the normal. And this was a 6-month follow-up where this anterior fracture seems to have fused. And here I would want to ask you how many of you would put a transverse connector in such type C injuries?
So Ranjit has raised the hand.
Yes.
So he could put.
I put 3 columns, yes.
Yeah, I used to put, but then I think I don't remember last time when did I put.
So for type C, for me, it is not MI, it's open for me, type C. And I really fuse them because it's a ligamentous injury. I align the column, fuse the back, do everything possible to maintain stability. For me, a transverse connector is one of the way to increase my rotational stability and the axial pullout.
Then one or two.
One One at the fracture site.
One
Okay.
at the okay. And for fusion, what do you do? So do you do a
Orthograph.
post-lateral?
No, I use all the lamina possible. I drill and burr all the facets. I don't harvest any graft in these patients. No adding the mobility. You got lots of graft from this because you have all the spinal process which you exposed. I shingle them all. Use that bone.
Okay.
Okay, Sahil, let's conclude.
Yeah. So this is pretty much it. I have presented my case now. I think the take-home message is that in type C injuries, long segment fixation is the way to go forward. And in injuries like these, if it is an incomplete spinal cord injury, you have to use reduction screws in the upper segments and try to manipulate carefully, slowly distracting and pulling these, using all the reduction maneuvers, possibly doing a facet resection or a shortening the column if you're not able to achieve, and if you have to do more distraction. And if it is an Asia A, then you can do whatever maneuver you're comfortable with. And the end aim is to have a completely aligned spine with a patent canal, if possible.
Thank you, Dr. Sahil. That's wonderful.
Dr. Guru, I think there should be one interesting comment from Dr. Ajoy Shetty, because he has published recently that even in type C injuries, you don't need to fuse. He has published that even type C injuries, you don't need to fuse. You can just stabilize and you are increasing in excellent outcomes.
Basically, because in any fracture, see the concept, if you take, you said about MIS fixation. If you take in 2000, people never used to do MIS fixation because they always used to say in all fractures, fusion, like any fracture, you have to fuse it. But with the advent of MIS screws, now people do MIS fixation. There are publications of MIS fixations in ankylosing spondylitis in type C injuries also. The same principle, we have never been fusing for more than 20 years and we have not faced implant failures. Basically because you need to have a stable fixation, aligned fixation, the fracture heals, soft tissue heals without any major issues.
You mean the anterior column heals? The
anterior column will heal if you have a stable fixation.
Okay. So thank you, Sahil. You can unshare. Right. Okay. I would request Dr. Ajoy Shetty, the past secretary of ASSI and Chair Education Committee, to conclude the session. And it has been a wonderful session. So over to you, sir.
Thank you, Guru. At the outset, my thanks to both the ASSI for giving this opportunity and for the BSS, Professor Shah Alam and all the faculty members for taking time at the end of the day to be with us. I would like to thank my co-faculty, Professor Chabbra, Ranjit, and the coordinators, Guru, and all the faculty from the BSS for being with us. It was an interesting session. And this will be relayed during the ASSI in Mumbai. And we will be sharing the details with the members of the BSS. Thank you all again and good night.
Thank you. And we hope to see you all.
Sir.
Bye.
And Happy New Year.
Thank you very much.
Thank you.
Thank you.
Thank you all.
See you in ASSI.
Yes.
ASSI, right. See you in ASSI.
Thank you. Rishi, you can end the meeting.
Dhanyabad.
Thank you.
দাঁড়ান একসাথে যাবো দাঁড়ান ব্যস্ত হয়েছেন তো